Thank you so much, Tony. I'm going to be beginning our talk today, and then Bob will be joining me about halfway through. So just to begin with our disclosures, so Dr. Grundmeier is a co-inventor of the Care Assistant Decision Support Framework. This is used for clinical decision support and research recruitment. He has no patent and has received no money from this invention. I have no conflicts of interest to disclose, and to inform you that our funding came from the National Library of Medicine grant with Dr. Grundmeier as our PI and through AHRQ. So our learning objectives today, we want to focus on a review of the revised American Academy of Pediatrics policy statement from July 28, 2014, regarding the use of palivizumab for children who are at risk for RSV or respiratory syncytial virus. We want to learn how the RSV care system was developed as a part of the Guidelines into Decision Support, or GLIDES project, and understand how clinical decision support tools, specifically the RSV Care Assistant, can help practices manage the entire process of RSV prevention and palivizumab administration, from identifying those at-risk babies via the translation of these complex clinical guidelines. So what I would like to do in the first half of our time speaking together is to really take you through in detail a summary and explanation of these new AAP guidelines. So we had this updated statement, the guidance for palivizumab prophylaxis among infants and young children who are at increased risk of hospitalization for respiratory syncytial virus infection. This was co-written by the Committee on Infectious Diseases and the Bronchiolitis Committee within the AAP, and you can see where it is found there within pediatrics for its publication. And again, we're going through both the policy statement and the technical report. So just to give you some background to start with, palivizumab is a monoclonal antibody produced by recombinant DNA technology and is directed against the respiratory syncytial virus, or RSV. It was licensed for use initially in June of 1998 by the US FDA for the prevention of serious lower respiratory tract disease caused by RSV in pediatric patients who are at high risk of severe disease. And the reason why I called out those two sections is to make it clear that it was not licensed for use to prevent RSV infections in all patients, for all types of RSV infections as well, but really focused on those high-risk patients for serious lower respiratory tract infection and disease. They didn't give us much detail in that approval and licensure statement around specifically the guidance for how this should be administered. So the American Academy of Pediatrics has published an initial policy statement on the use of palivizumab in November of 1998, and has subsequently gone on to revise this statement in 2003 and 2009, and then again most recently on July 28, 2014. So the basis for their recommendations and for the revisions that they have made are around review of data in numerous areas, including the hospitalization rates for RSV, mortality, RSV seasonality, the palivizumab pharmacokinetics, the benefits of prophylaxis, and the reports on palivizumab-resistant RSV isolates that have been found in hospitalized high-risk patients, as well as looking at cost-effectiveness analysis because of what we all know is the very high cost of palivizumab. So just to review some things about the RSV season, so in our part of the country, the RSV season is running from November through March. The full series of palivizumab administers 5 doses given every 28 to 30 days, so approximately monthly. The dose is 15 milligrams per kilogram delivered IM. And after administration of 5 monthly doses, the serum concentrations of palivizumab remain at or above the protective levels that have been defined in studies for most children for 6 months. So while they get 5 doses over the course of 5 months, they are able to achieve serum protective levels for 6 months total. So when we think about the risk factors for RSV, there's been a lot that's been talked about in the numerous policy statements about the risk factors for patients. But the single most important risk factor for RSV hospitalization is actually chronologic age. And I put this out here at the beginning because this provides a basis for some of the changes that were made in this policy statement versus the previous statement in 2009. So more than 58 to 64% of pediatric RSV population, infections, occur in the first 5 months of life. And the degree of increased risk for certain subgroups, when we think about preterm infants, infants with chronic lung disease, and hemodynamically hemodynamically significant congenital heart disease, those degree of increased risk vary among the various studies that they reviewed. So when we think about the targeted populations for palivizumab, the safety and efficacy data were initially established in 3 core populations. So those are premature infants, children with bronchopulmonary dysplasia or chronic lung disease of prematurity, and children with hemodynamically significant congenital heart disease. As the policy statements have come through, then we have additional populations for consideration, which include children with congenital airway abnormalities or neuromuscular disease because they have compromised secretion clearance, immunocompromised patients, and patients with CF or cystic fibrosis. So just to go through each of the populations here, and I wanted to contrast for you the 2009 versus the 2014 guidelines. So looking first at premature infants. So this is looking exclusively at their degree of prematurity, not other comorbidities. So in the previous guidelines, all children who were born at less than 29 weeks gestation, so that's defined as 28 weeks and 6/7 days or less. If they were 12 months old at the start of the season or less, they were eligible for 5 doses. That has continued into the 2014 guidelines. So less than 29 weeks gestation, so 28 and 6 or less. As long as they are less than 12 months old at the start of the season, that's November 1st, they're eligible for 5 doses of palivizumab, which will carry them through the entire season. The differences come in the later stages of prematurity. So in the previous 2009 guidelines, for those infants who were 29 to 31 and 6 weeks gestation, if they were less than 6 months old at the start of the season, they were eligible for 5 doses or a full series. In the 2014 guidelines, those patients are no longer eligible based solely on their prematurity. So palivizumab is not recommended unless they have other comorbidities such as chronic lung disease or significant congenital heart disease. Furthermore, in the 2009 guidelines, there was eligibility for the later preterm infants who were 32 to 34 and 6 weeks gestation. If they were less than 3 months at the start of the season and they had one or more of the following risk factors, which was a child attending childcare or daycare, or having at least one sibling or long-term household contact that's less than 5 years old, they would be eligible for a maximum of 3 doses that would carry them through until they were 90 days of age. Once they hit 90 days of age, their doses would stop. They would no longer be eligible because that was deemed as their highest risk period. That guideline has now gone away, and this is not included in the 2014 guidelines. So patients who are greater than or equal to 32 weeks gestation are not recommended for prophylaxis unless other comorbidities are present. Those comorbidities, as we talked about, would be chronic lung disease or significant congenital heart disease. It's important to note here that one conspicuous absence in the 2014 guidelines is that preterm infants and children are not eligible during the second year of life on the basis of their prematurity alone. Only if they have an eligible comorbidity, specifically chronic lung disease, that could make them eligible for the second year of life. So when looking at the data that was provided in the technical report by the AAP, they spoke about data gathered by the New Vaccine Surveillance Network, where they showed that the previously reported potential risk factors, including siblings in the household and child care attendance, these were not associated with a significantly increased risk of RSV hospitalization. And that was the reason why that recommendation was removed from the 2014 guidelines. Additionally, the RSV hospitalization rate increased with decreasing gestational age, with a break point at less than or equal to 28 weeks gestation. In other words, those infants who were more preterm had a lower gestational age at birth, they were at higher risk of hospitalization from RSV. And again, the intention of the palivizumab series is to prevent serious lower respiratory tract infection with RSV. And that cutoff at 28 weeks, which takes you up through 28 and 6, seemed to be the area where you had a multifold increase in the risk of hospitalization versus the low-risk population. Infants born before 29 weeks gestation have hospitalization rates that are 2 to 4 times higher than that of later preterm infants. So moving on to look at the children with chronic lung disease. In the 2009 guidelines, they described infants with chronic lung disease, and they didn't give a very clear definition of what chronic lung disease would mean. But they did say that infants and children who were less than 24 months at the start of the season with chronic lung disease who require medical therapy within 6 months prior to the start of the season would be eligible for a full 5 doses, so the entire series of palivizumab. The medical therapy was defined as chronic corticosteroids, diuretic therapy, supplemental oxygen, or the use of bronchodilators. In the updated guidelines, there is a clearer definition of chronic lung disease, but they specifically call out preterm infants with chronic lung disease. So they define this as children who are born at less than 32 weeks gestation, so that's 31 and 6 weeks, and those who require greater than 21% oxygen after 21 days of life. If you meet those criteria, that meets the definition for the purpose of this guideline as chronic lung disease of prematurity. Meeting that definition would make a patient eligible for 5 doses, the full series, during the first year of life. So long as they are less than 12 months old at the start of the season, November 1st, they would meet criteria for 5 doses. Now, the second season consideration for patients with chronic lung disease, and this is really one of the focal populations for the second season of eligibility. So if they meet that criteria of chronic lung disease of prematurity and they require medical support during the 6 months prior to the start of that second season, they would be eligible for 5 doses. That, again, the medical support would be defined as chronic corticosteroids, diuretics, supplemental oxygen, and bronchodilators. The next population is the hemodynamically significant congenital heart disease, and that significance is really an important feature of this recommendation. So in the 2009 guidelines, the definitions around being hemodynamically significant really didn't change. What's really different is the age cutoff. So in the 2009 guidelines, children were eligible up through 24 months of age. So as long as they were less than or equal to 2 years at the start of the season, they were eligible for a full 5 doses for the season, so long as they fit those eligibility criteria. In the 2014 guidelines, they have to be less than or equal to 12 months at the start of the season. Additionally, in the 2009 guidelines, they specifically called out the eligible diagnoses as acyanotic or cyanotic heart disease that is receiving medications for congestive heart failure or would require corrective surgery for that congenital heart disease lesion. Additionally, pulmonary hypertension defined as moderate or severe, and then a recommendation around a postoperative dose after bypass for those patients who would be deemed eligible for the remainder of the season even after their corrective surgery. In the 2014 guidelines, there was some separation out between acyanotic heart disease and cyanotic heart disease. So in reference to acyanotic heart disease, they'd be eligible if they were receiving medications for congestive heart failure and will require corrective surgery. Pulmonary hypertension, defined as moderate to severe. And then for the cyanotic heart disease lesions, they recommended this in consultation with the cardiologist to determine their eligibility. And again, kept the consideration for a postoperative dose after bypass or ECMO for eligible patients. And then specifically put in a recommendation to consider a dosage for those patients who are less than 2 years old who are undergoing cardiac transplant during the RSV season. So looking at the data for children with congenital heart disease, the technical report called out a study by Feltes et al. That demonstrated a greater impact on RSV hospitalization rates in patients with acyanotic heart disease versus cyanotic heart disease. And that was why they separated those out in the 2014 guidelines. They also discussed a retrospective analysis of children who are less than 3 years of age that was presented by the Tennessee Medicaid program, in which they showed that the hospitalization rate for patients with congenital heart disease in the second year of life was less than half of that of low-risk patients who don't qualify for any prophylaxis in the first 5 months of life. So therefore, the prophylaxis was only recommended during the first year of life. So if you have low-risk patients who have a far greater risk of hospitalization during their first 5 months of life versus those patients with congenital heart disease in their second year of life, that was why they removed that recommendation to continue the prophylaxis into the second year for these significant congenital heart disease lesion patients. They also made a specific comment that as the rate of RSV hospitalization decreases among children who do not qualify for prophylaxis, or who do not receive prophylaxis, because we know that we are not achieving universal coverage of those eligible patients, the cost to prevent one hospitalization with prophylaxis thereby does increase. So additional populations for consideration are children with anatomic pulmonary abnormalities or neuromuscular disorders. And the emphasis is on these conditions that impair secretion clearance because of an ineffective cough. These patients are eligible if they meet this criteria and they are less than 12 months at the start of the series. They did call out that there are no prospective studies or population-based data available to support this recommendation, but they would be eligible for the 5 doses throughout the entire season if they meet this criteria. And then looking at children with cystic fibrosis, one of the differences between the 2014 versus the 2009 guidelines is they had much more specific criteria in the 2014 guidelines around this population. So they said that routine use in all CF patients under the age of 2 is not recommended. But in the first year of life, it's only indicated if there's evidence of significant chronic lung disease and or nutritional compromise in those CF patients. And then in the second year of life, it may be considered if there is severe lung disease. And they specifically called out a definition around severe lung disease of if they had a hospitalization in the previous season for pulmonary compromise from their CF, that could rate them as having severe lung disease in that second year, or if their weight for length percentile was less than the 10th percentile. In the immunocompromised population, this is another group that was permitted to be eligible up through 24 months of age, even in these updated 2014 guidelines. So specifically focused on profoundly immunocompromised patients during the RSV season. And they were able to give a little bit more clear guidance on this as well, looking at the absolute lymphocyte count of less than 100. Less than or equal to 100, excuse me. And then one of the populations that has been discussed in the past for palivizumab use is children with Down syndrome. They did call out in these guidelines that there's limited data to support the use in this population unless there are other qualifying conditions present, such as chronic lung disease, congenital heart disease, airway clearance issues, or prematurity. So the existence of their Down syndrome diagnosis alone would not make them eligible. They would have to have one of the other eligible diagnoses present. So we think about particular hospital use of palivizumab. They made a little bit more specific guidance as well. So the first dose for eligible patients should be given to eligible patients 48 to 72 hours prior to discharge or promptly after discharge. It's worth noting that in patients who are going home for the first time during the season, getting their very first dose, it is wise to give that dose before they go home, because it is going to take some time for the primary care provider to pursue the application process for an approval for palivizumab. It is not recommended for control of outbreaks in healthcare settings for prophylaxis to other patients on that unit. So if there is an outbreak of RSV in a neonatal ICU, it is not recommended to give palivizumab to other patients in that unit. This is a key difference. It is recommended to discontinue the series in patients who are hospitalized for RSV infection. The reason for this recommendation that they called out is due to the very low likelihood of a second hospitalization in the same season for that patient. And again, because the guidance for the use of palivizumab is intended to reduce the risk of significant lower respiratory tract infections and looking at those that require hospitalization. They do not make a specific recommendation to discontinue the series in patients who have RSV infection but do not require hospitalization. So that is going to be left open for interpretation of the providers throughout the course of this season. And then they also recommended strict adherence to infection control practices, specifically within the hospital setting. I think it is important to note that in the 2009 guidelines, there was a specific comment that should a patient be admitted during the course of the season who had already started the series, and they happened to be admitted when their next dose was due, that it was advised to give them that dose while they were in the hospital so as not to get them off track in the timeliness of receiving the doses. That was not addressed in the 2014 guidelines, and so there is still some remaining ambiguity around those patients who are admitted for hospitalizations other than RSV in terms of what should be the practice in terms of keeping them on track for their palivizumab administration during that hospitalization. So just to review the notable changes in these updated guidelines, there was a lower gestational age cutoff for prematurity alone, so without those other comorbidities. There's reduced second season eligibility, so it's focused on preterm infants with chronic lung disease who continue to require therapy within the 6 months prior to the start of the season, profoundly immunocompromised children, and those CF patients who meet that very strict criteria during the second year of life. There is a clear definition around chronic lung disease of prematurity, a clarity of the recommendation in the CF population, and then the recommendation to discontinue the use of palivizumab after having a breakthrough RSV hospitalization. And again, part of that was around the goal of reducing the hospitalizations, but also because they were able to isolate some palivizumab resistant strains of RSV in patients who were hospitalized for RSV infection. So with that, I would like to welcome Bob to speak about how this interfaced with our project.
Thank you, Annique, and thank you, Tony, for your kind introduction before. And thank you for listening into this talk. It's been a fun project for many of us. You'll see actually towards the end the acknowledgement slide. This is really the work that was done by a large team of people. And also we benefited from a fair amount of funding from external sources through the ARRA grants that were made available. One in particular was the AHRQ Glides project, which was led by Rick Schiffman at Yale, and we had the opportunity to be one of the collaborating sites alongside numerous other giants in the field. And I just wanted to point out one of the specific aims of this particular grant mechanism, which is sort of aligned with a discussion about changing guidelines and what happens as you're trying to improve healthcare in an evidence-based fashion. As part of the project's work was to actually work with guideline developers to provide tools and guidance to improve the actual guideline development process and the reporting of outcomes related to those guideline implementation efforts. We were very much focused on actually implementing a guideline, and it was the Academy of Pediatrics guidance on RSV vaccination, which was really quite well written. But there are many other guidelines out there that are much harder to translate and actually implement as an automated decision support system. So this project, the story of our project began in 2010, and we had received some funding from the NIH, and we wanted to do a project with our local pediatric research consortium as kind of a benefit to the practices. So this project was designed in a lot of discussion with the CARE network itself. So we came up with a project related to premature infants, and we identified 7 domains of the primary care of these patients that we wanted to try to improve using a decision support intervention. And I list here the 7 different domains that we targeted, only one of which is our topic today, which is the prevention of respiratory syncytial virus. We were also looking at growth, nutrition, development issues, screening for blood pressure, which was quite challenging for our practices to implement, follow-up for retinopathy of prematurity, which is an eye disease experienced by premature infants, and also some documentation related to the NICU course. At the same time that we were designing this research study, the Primary Care Network was also looking at a network-wide quality improvement project and had chosen palivizumab administration rates as their target. This created a situation where we were trying to align our research agenda with an ongoing quality improvement effort. And so when this happens, and there's sort of a collision between a researcher who wants to cluster randomize a bunch of sites to receive different interventions and a quality improvement agenda which really wants to push out some improvement in the care received by patients across all sites. And this actually, I think, is becoming more and more common. I've personally been involved in 3 projects where this occurred related to immunizations, asthma, and now for premature infants. So this is something as researchers, especially in the clinical informatics arena, that we have to keep in mind. So we sat down with the CARE Network to kind of review the scope of the work we were doing and the problem. And we knew from some data that the CARE Network had collected, as well as data that we helped them collect from the research perspective, that only 56% of the children who were eligible at that time to receive palivizumab based on the 2009 guidelines actually received at least 4 of the 5 doses that were recommended. This was in the 2010-2011 season. So from our perspective, we wanted to choose half of these practices and say, we're going to help you do a better job. However, that was really not a viable option, considering that there was such a significant problem immunizing these children across the care network. So in discussion, we decided to come up with a set of tools related to palivizumab administration that we could provide to all the practices participating in the research study, more or less as a benefit of participating in the clinical trial. And then we randomized other items which are not really related to palivizumab administration. So once we had decided how to set up the study, and we're going to do sort of a pre-post comparison of the effect of implementing RSV guidelines in the point of care, we then had to sit down and actually understand the guideline, which, as I mentioned, this is a pretty well-written guideline, and this is the 2009 guideline we were working with initially. And we sat down, we had a number of domain experts who helped us to dissect this text sort of in a vacuum, not at the bedside. We just tried to understand what were the guideline authors actually trying to tell us to do. And the first step of that was to identify the text in the document that was actually relevant to particular recommendations. And we used a tool called the gem cutter tool, which was developed by Rick Schiffman and his colleagues at Yale, to really dissect these documents, which we found very helpful to really break it down into little digestible pieces that we could then discuss as a team. And as shown in the third column there, the next step in that is to actually write some pseudocode with Boolean logic related to who might be eligible or meet criteria for a particular recommendation. And then as a final step, which was a miracle from the programming team, you then code some really obtuse-looking executable rules, which the guideline authors might look at this and say, well, I see a few things in here that might look like the guideline we wrote. But it takes work to actually take these guidelines and create software that mimics or implements these recommendations in an electronic health record. If you look closely, you can see things like, oh, right, here we're talking about an integer interpretation of age at month start being less than 24. But this is not something you put in front of a clinician to understand. This is work that needs to be done by experienced programmers with guidance from domain experts. What the guidelines don't talk about, but we feel is really quite important, is to actually understand the tasks that need to happen to affect how healthcare occurs. And in this case, we underwent a prolonged period of understanding what the RSV coordinators actually had to do to get palivizumab administered to the eligible children. And Dean Caraviti, who kindly provided a number of these slides, actually sat down with many people, interviewed them, took pictures of their artifacts, which included all these shadowed charts, because there are really no tools in the electronic health record to help them with their tasks. So they created tools outside the electronic health record that are based on paper. And there's sort of a notch sign over here indicating that one of the secondary goals of the project was to try to eliminate some of these paper artifacts and bring it into the electronic health record. So there are numerous steps that the referral coordinator, RSV coordinator, needed to do, including interpreting the AAP criteria, determining who's eligible. There's a whole column of tasks related to insurance approval process, and then once kids are approved, there's a cycle of steps that they have to go through for every single one of the 5 doses, from scheduling an appointment to estimating the amount of the product that they need to order for the next dose, actually getting that dose and doing some inventory management to know that it's in the fridge, and then having the child arrive at the right time, having the dose in the fridge, and then actually having somebody realize that the dose needs to go into the child when they're in the office. And all of this has to happen successfully 5 times during a very tight time window. It's very hard. And we'd just like to highlight that the guidelines are primarily speaking about this first box here, which is who's actually eligible, and really don't give any guidance to the informatics team about how to deal with insurance management or inventory management or alerting people to give the dose when the child is in the office. That's all left as an exercise for the sites. So our first step was based on what we'd learned from the guidelines, as well as our interviewing of every RSV coordinator who we could get on the phone or in person, was to build some tools. And we ended up building essentially 2 tools with a few little adjuncts to help with this process. In the foreground at the bottom left is the tool that we delivered to help the RSV coordinator with the patient who is in front of them at a particular time and allows, or that they were addressing at one particular moment. They can document their intention to refer for approval from the insurance company. They can document who would actually be providing the product through the Synergist distributor field. And then they can record whether they had to appeal that process. And all this can be tracked in one place for a given patient. On the sort of background at the top right is the tool that we provided to help the RSV coordinator with all of the patients in their practices, which is a list of all the patients who are eligible for RSV, and there's a column that describes whether or not the insurance company has approved it, how many doses were approved, and then there's information which is blacked out because it's patient identifier information. There's information about the date they last got the dose, when they're next to due, is there an appointment scheduled for that, and a lot of workflow support for the person who is actually contacting these patients and bringing them into the office for their doses. And from the interviews with these coordinators, they indicated that they spent many, many hours over the course of the season. I think we heard estimates from 8 hours per child to up to 40 hours per child of work that is done by one individual to actually succeed in getting these doses into the eligible children. I just wanted to mention as an aside that in addition to the RSV tools, we were actually doing a randomized clinical trial in parallel to the clinicians, which was a knowledge intervention about the 7 domains that I mentioned previously. And this is a screenshot here showing what the clinicians actually were interacting with in the intervention practices, of which there was one little component addressing RSV eligibility appearing sort of towards the bottom of the screen with the red exclamation mark. But this was sort of alongside numerous other aspects of premature infant care that were also being addressed. So at this point, with about 10 minutes remaining in my remarks, I'd like to talk about what we actually observed to happen as part of this intervention effort and the evaluation that occurred. And this information is thanks to Annique, actually, who presented this previously at a pediatric academic society to get us started. So overall, it worked. The intervention increased the number of patients who received at least 4 doses of palivizumab during the post-intervention season, and we found that the impact was greatest amongst the urban practices, where there was actually quite a low baseline success rate. In the pre-intervention season in the urban practices, only 28% of the children actually received at least 4 of the doses that were recommended, compared to the suburban practices, who were doing much better. 78% of their children, eligible children, were getting 4 doses. In the post-intervention season, everybody improved. The urban practices doubled their rate. Still, only about half of kids were actually meeting the target, which was a little disappointing, but doubling the rate is pretty good. And we were pleased to see that the suburban practices also had a reasonably significant improvement in the proportion of children who actually succeeded in getting at least 4 doses. They increased by about 9 percentage points in the post-intervention season, from 78% to 87%. And overall, this represented about a 9 percentage point improvement across all the practices. Thanks to, again, to Annique. I'm so glad I get to stand up here and take credit for so many people's hard work. So Annique read through these charts and tried to figure out, among the children who did not get even 4 doses, what went wrong? Why were they not getting their doses? And in the baseline season, by far the biggest problem was that people were simply not recognizing that the children were eligible at all. When Annique went back to figure out why didn't they give RSV, the most common reason was did not give palivizumab, excuse me. The most common reason was there was no mention of any concern about RSV risk or eligibility for palivizumab anywhere in the chart. And we actually in the post-intervention season saw that number fall substantially, where virtually all the children, or at least there was some discussion in the chart. The chart was no longer silent about the issue of palivizumab and RSV risk. And instead what happened in the post-intervention season was some of the problems that were there in the pre-intervention season actually became somewhat magnified or unmasked as we recognized eligibility for kids. There was problems with scheduling. The number of children who were affected by scheduling-related issues where they were not scheduled for an appointment to actually receive the dose doubled. There are significant numbers of mentions of difficulties in contacting families, which was not actually an item that we recorded in the baseline period to record, but it was a significant driver of the failure to administer palivizumab in our intervention period. And then distressingly, even when everything happened right, the dose was in the fridge, the kid was in the office, they knew that the child was supposed to get it in spirit, when the child was actually there in the office, they didn't get the dose. Which actually the number of times that occurred doubled in our intervention period. You might notice some change in insurance denial and family refusal. We did not feel, because those numbers were still quite small, there were some interesting stories there that we can discuss, but that wasn't the main reason why kids were not getting the doses. Then last night, as I was preparing this talk, I said, I need to show this audience something new, because some of these people have seen these slides and may have checked out by this point. So I said, I gotta show them what we did. So I looked at some data yesterday evening. I said, well, let's take a look and show sort of in a colorful way what the intervention did. Green is good, yellow is less good, and red means that the children got 3 or fewer doses. So green means that they got 5 doses. And we looked at the 7 biggest practices who had the largest cohorts of eligible premature infants. And we looked at it and said, okay, the first season, about 50-50. Next season, a little bit better. And then the third season, really a lot more green in that. And the funny thing is, when I did this, I thought that I was looking at 2 baseline seasons and 1 post-intervention season, because I am terrified to see what happened with this intervention after we stopped analyzing it from a research perspective. I've been scared to look at the data because I'm afraid we'll find out that all the benefit went away. Then at about 1 in the morning, as Annique can attest to from an email last night, I realized, wait a minute, I was looking at 2 post-intervention seasons in that slide. So in fact, the modest improvement that we see is actually the 2011-2012. That was the intervention season we evaluated. And you can see the green bars are a little bit bigger. But the big impact was actually in an intervention season that we hadn't even looked at. This is just aggregate data that I pulled together. It's just premature infants. These are kids who are eligible based on prematurity alone, based on the 2009 guidelines. So then at 1 a.m. I realized, I made a mistake that might have been in my favor for this talk by actually braving the new data, the one that I was afraid would say all that hard work that we did turned into nothing when we stopped looking. But in fact, it actually continued. So I, emboldened by this, I looked at the summary statistics for the most recent season, 2000-2014 at the right. And what we see is that actually we've had a sustained benefit. On this scale, the first 2 circles and bars on the left are showing what happened in the 2 baseline periods before we did anything. And then we did a bunch of things. We saw about a 9 to 10 percentage point increase, and that's actually been sustained. In fact, our best seasons were the last 2 seasons, which we didn't even actually, are not part of our planned analyses. This, again, is just aggregate data, and there could be numerous flaws, but it's appealing. So then I decided, somebody in the audience is going to say, but this doesn't matter anymore because hardly anybody's supposed to get palivizumab because Annique just said nobody needs palivizumab, which is not what she said. She actually said there are changes to the guidance. There are still many kids who are eligible. Based on some other numbers we've looked at, we estimate about 30% fewer kids, but still about 2/3 of the numbers of kids that we were giving palivizumab to previously would still be eligible. So I looked at, let's apply the 2014 recommendations based on prematurity less than 29 weeks, who got at least 4 doses. And in fact, the numbers are basically the same in terms of our success rate for that 2014 at-risk cohort as for the 2009 cohort. If you go back and forth, you sort of see that the numbers are basically the same, just a little bit of a change in the error bars because there's fewer subjects. So we believe that this is still an important problem for offices to pay attention to. As I mentioned, there are some limitations to the analyses that I've shown here. We are looking retrospectively at electronic medical records in a single network. There may be shadow charts out there that contain important information explaining why children did or did not receive palivizumab that was not available to us because it was on paper on site. We did not include any information in this summary related to complex congenital heart disease or chronic lung disease. These were just purely data from premature infants that we discussed. I'd like to briefly, in the closing couple of minutes, talk about what it required for us as an informatics team to respond to the new guidelines which the AAP dropped on our head late in the summertime when everybody's on vacation and not wanting to suddenly reprogram all of their decision support systems. So the good news is we spent many hours in building the system. Jeff Miller, who's in the audience here, had many sleepless nights helping us to set this up in the first place. And really the incremental work that our team had to do to deal with the changes this season was relatively modest. It was about 7 hours spread between Annique, myself, Dean Caraviti, our data analyst, Mark Ramos, between understanding the guidelines, interpreting the guidelines, iteratively recoding the queries and the rules, and then Mark actually doing the hard work, which is to make the queries actually work and to run them and distribute the data. So this was fairly modest compared to the amount of effort that people need to spend just dealing with palivizumab on site every year as they're calling people and scheduling them. Very modest compared to the amount of work that we did up front. So I feel like this shows that it was pretty feasible to update a decision support system when you have clear guidance from an expert body of what needs to be updated. So in summary, for my portion, we were able to, with our intervention, correctly identify the majority of eligible children who are eligible to receive palivizumab thanks to this project. There was a modest improvement overall in how many children actually received at least 4 doses. And the benefit does appear to be sustained even though the study is over. But there are some ongoing opportunities for improvement even in the face of new guidelines related to scheduling efforts to ensure that appointments are made for children to receive the vaccine, the immunization, and that efforts are made to follow up with children who do not show for appointments, and that we make sure that we take advantage of all opportunities to administer palivizumab when the child is in the office. And we felt that overall the effort required by the informatics team to respond to the updated guideline that arrived during summer vacation was fortunately relatively modest. For our next steps, we're now transitioning the RSV Assistant into a more sustainable form, which will be supported by IS through a reporting workbench feature, which is shown here on the slide, and that we are doing ongoing evaluation of the rest of the project to decide which portions of the decision support warrant ongoing implementation versus which portions of the 6 additional domains that we targeted could be retired, because we need to be very cautious about alert fatigue issues and overwhelming clinicians with alerts that don't actually change healthcare. I'd like to acknowledge the many people, some of whom I've named in person, a few others whose names are here on the slide that you can see. Many domain experts helped us out, and I'm very thankful to the numerous analysts, programmers, and statisticians who helped keep us sane and helped move the project forward. So at this point, I'd like to thank you all and open the discussion for any questions. Thank you.